I am a doctor.
I am a data collector.
I'm a pharmacist.
I am a clinician.
I am a counselor.
I am a nurse.
When the AIDS pandemic hit, we had information, but with COVID-19, we were never ready for the real impact.
We are frontline workers regardless of a pandemic.
We had to become resilient. That was our biggest motivator.
We are health providers.
We are health providers.
We are health providers.
We are health providers.
Pata pata, pata pata, pata pata, ipata pata. Mtenga taliba chika heza. Hai sa bukuka sa tibega. Sa bukuka sa tibega. Sa bukuka sa tibega. Sa bukuka sa tibega. Pata pata,
Hello, everybody, and welcome to this Africa Cafe session. I'm Anna Grimsrud. I'm joining you today from South Africa, and we're really excited that you've decided to join us for the next hour and 15 minutes, where we're going to talk about differentiated service delivery to reach young people, including children and adolescents, both for their HIV needs and their other health needs. Now, before we get started on our presentations, I wanted to make sure that you got to say hi to the panelists and the people that we're going to be discussing things with today. So first, I'd like to invite Franklin to go ahead and unmute himself and turn on his camera and say hi to everyone.
Hi, good afternoon, everybody.
Hi, Franklin. Where are you joining us from today?
Yeah, I'm Franklin. I'm joining from Nigeria, Abuja, Nigeria. Hi, everybody.
Great. Thanks so much, Franklin. Next, I'd like Rebecca to go ahead and unmute and turn on her camera and introduce herself to everyone.
Hi, everyone. I'm Rebecca Sher. I'm joining from Cape Town, South Africa.
Excellent. And David, would you like to unmute and turn on your video, please?
Hi, everyone. I'm David Ogiti, joining from Kenya.
Great. Thanks so much, David. And Cosima?
Good morning, good afternoon. I am joining from Ohio, USA.
Welcome, Cosima. We're also really hoping to have Dorian join us from Nigeria as well. So when he joins us, I'll give him the opportunity to introduce himself. So without further ado, I'm going to go ahead and share my screen and share some slides with you about this session. All right. So as I said, today we're here to talk about differentiated service delivery for children and adolescents, meeting their HIV needs and beyond. Now, there's many of you that have joined from all over the region, and so I really want to encourage you while I'm presenting here to introduce yourself to us in the chat so that we know who you are. And then throughout this whole session, if you have any questions, please put them into the Q&A part of the Zoom room so that we can answer your questions. Cosima, Franklin, Rebecca, David, they're all here to answer your questions, and they've pre-recorded their videos so that we have maximum time for you to interact with them. So like I said, introduce yourself in the chat and ask us your questions in the Q&A. So differentiated service delivery or differentiated care is a person-centered approach, and it simplifies and adapts HIV services across the cascade, both to reflect the preferences and expectations of various groups of people living with or at risk of acquiring HIV. Now, throughout this presentation, you're going to hear about different models of differentiated service delivery, and our presenters are going to talk about the building blocks. So they're going to share their model and describe when it is offered, where it is offered, what cadre of staff are involved in the provision of services, and what services are provided. And so we see these as the building blocks. And you can use the building blocks both to discuss HIV treatment, or you can use them to talk about HIV testing, or you can use them to talk about service delivery for any sort of healthcare need. Earlier this year, the WHO revised their definition of who is eligible for differentiated service delivery for HIV treatment. And so instead of talking about stable, they now talk about whether or not a person is established on ART. What's really important here is that this definition is inclusive. It includes all populations, and very specifically, as you can see in this purple quote, it talks about how children and adolescents should also be included in DSD for HIV treatment models. Now, when I talk about DSD for HIV treatment, I will always end up putting the models into one of four buckets. So on the top, you've got group models, and on the bottom here, you've got individual models. In terms of group models, what we're really interested in is who convenes or moderates or manages the group. So you might have groups that are managed by the healthcare service, and those. Good morning, good afternoon, Dorian, how are you? Go ahead and just mute yourself for now, thanks. So you would think of things like teen clubs, where there would be a facilitator from the health facility, or you could have group models that were managed by people living with HIV themselves, such as family ART groups. And then on the bottom, you've got individual models. So these could be models that take place inside a health facility, like an adolescent corner, or you could have individual models that are outside of the health facility, such as outreach or youth center pickup points. And we've got some really great examples from our presenters today that highlight different types of DSD for HIV treatment models. Now, on this really busy slide, what I've shown is one of our dashboards here, where we've looked to see in national guidelines if children, or those between the ages of 0 and 14 years of age, are eligible to join a DSD for HIV treatment model. In teal, or in the blue color, is where countries were before COVID, and in orange is where they were after COVID, or what policies they put in place during COVID to make sure that people had access. And you'll note on the far left-hand side that many countries currently exclude children, or they don't specify whether or not children or adolescents are eligible. And so there's a lot of work to do here. We know that, and we heard this yesterday as well, that there's actually not so many dose changes that are required for children over the age of 2. And so in this paper, it was really highlighted that these ART dose adjustments do not mean that people need to come to the health facility all the time, as there's only 3 dose changes that are anticipated between the ages of 1 and 7 years old. And so we really want to make the case that children and adolescents don't always need to be necessarily seen at the health facility, depending on what their needs are. Here, just briefly, is really another busy slide on the dashboard. And again, in the teal and in the orange, you'll see a number. And this is the age band and what the maximum duration of a refill is in a specific country. So if we look at Zimbabwe, which is alphabetically at the bottom of this list here, you'll see that before COVID, those over 2, 5, 10 years of age and adolescents had a maximum of 3 months of ART refills that were provided. And then during COVID, special conditions were put in place in the orange to say that children and adolescents could access 3 to 6 months of ART refills. Globally, we saw during COVID, and this is for all ages, a real increase in the duration of ART refills offered. And so looking at PEPFAR data from 21 countries here, in the orange is 6-month refills, and in the teal is 3 to 5 months. And by the end of 2020, 75% of people supported by PEPFAR were receiving multi-month dispensing. Now, what you want to ask here is how did this, what was the data like for children and adolescents? And what's really exciting is that as a result of COVID, we saw the same trend happen for those 15 years and younger. So here again is the number and proportion of clients under the age of 15 on multi-month dispensing. And again, if you look at the last bar on your right-hand side, at the end of 2020, 7.5% of this population was getting 6-month refills, and 46% were getting 3 to 5 months of dispensing. And so we can really see that COVID led to an extension of the maximum ART duration for children and adolescents. Now, what's really important, and what you're going to hear a lot from our presenters today, is that DSD for HIV treatment is about more than just antiretroviral therapy, and it's about more than just HIV. And so here in these quotes, you can see that young people living with HIV, they have needs beyond just drug refills, and they have health needs beyond just HIV. And so we need to take these into consideration when working with children and adolescents to provide quality services. Finally, I just want to highlight some resources that may be of interest, and many of which are included in the PATA Summit resources, including this decision framework for children, adolescents, and families, a viewpoint on why children and their families are entitled to the benefits of DSD, and as well to flag that a really critical component of healthcare services for this population is sexual and reproductive health needs. And so we want to ensure with our DSD for HIV treatment options that we're also providing choice and a full range of contraceptive methods and easy access for this population. So I'm going to just give you a brief overview now of what you're in store for in this session. And then I'm going to get Dorian to come off mute and turn on his camera and introduce himself, because we're really glad that he's joined. So first, we're going to hear from 3 presenters, and they're each going to give us an overview of 3 different DSD for HIV treatment models. So when you have questions for them, please put them into our Q&A. Then we're going to hear about some lessons of multi-month dispensing. So some examples from an implementer on how they were able to extend ART refills for children and adolescents in recent quarters. And then we are going to hear from a Dorian who's going to tell us about meeting young people where they are, specifically with HIV self-test kits in Nigeria. And then we're going to transition to a really interesting discussion and live Q&A. We are going to post now in the chat for all of you a link to a Google Jamboard. And we're hoping that on this Jamboard, you can share your thoughts on and opinions with us on what are the barriers and facilitators to DSD. And also when we launch this discussion, we'll be asking you all to answer some poll questions. So please stay tuned to that. So now what I'd like to do is just check in and see if Dorian is still on. I believe he is, and ask him just to unmute himself and turn on his video. Briefly say hello to everyone and let's introduce yourself, Dorian, to the group that's on this webinar. Saw you briefly there. There you are. Yeah. Hi.
Good day, everybody. My name is Dorian Ezekiel. Nice to meet you all.
Great. And where are you joining from today, Dorian?
I'm joining from the metropolis of Uyo in Akwa Ibom, Nigeria.
Excellent. Great. So we're going to hear from you a little bit later. For now, I'm going to go ahead and let the first 3 presenters share their models. Thanks very much.
You're welcome.
Good afternoon, everybody. My name is Franklin Emerene. I work in Rice Project Nigeria. I will spend a couple of minutes talking about Operation 000 as implemented in the 4 states in Nigeria. So RISE means Reaching Impact Saturation and Epidemic Control, a USAID-funded PEPFAR project, which is operating in 5 states in Nigeria, supporting 53 local governments and 129 healthcare facilities. The RISE geographic spread and OTC target population. The focus population are single adolescents and young people aged 10 to 24 years, of which we have been able to enroll 5,207 out of eligible 5,857 individuals. So they have been established 48 standalone sites and 13 cluster sites, which the building blocks of Operation 000 are mainly the ART refills, clinical consultation, psychological support. So I walk through of the when, the where, the who, and the what of these building blocks. So the ART refills mainly happens monthly, 3 monthly, or 6 monthly, depending on the DSD model the adolescent or young person is. So it mainly happens in the facilities or at the OTC centers, and sometimes occasionally at homes, depending on the need of the child. So the clinicians are mainly responsible for prescription, while the case managers might do the refills at the OTC centers and the homes. So the major thing, what is given to them is mainly the TLD or optimal regimen based on the need of the individual. Clinical consultations are also monthly or 3 monthly. Even the adolescents and young persons who are on 6 monthly medications are also seen at least 3 monthly to ensure that they are seen more frequently at the clinics and addressed. So consultations mainly happen in adolescent centers in the healthcare facilities, and also sometimes in mainly also other places designated for consultation in the health facilities. And the clinicians are responsible for clinical consultations. So what is being implemented during clinical consultation is non-judgmental counseling, risk assessment for sexual and behavioral changes, and screening for opportunistic infections. Psychological support usually happens monthly at the adolescent centers, at the youth clubs, or at home, depending on the need of the child. So the case managers are responsible, trained case managers are responsible for providing this psychological support, also aided by clinicians. Then the adolescent pair, that's the OTC champions, also support in psychological support. And then the OV service providers also help in service psychological support. Then what is implemented is peer-to-peer support. Recreational activities were integrated into the clinical care, such as games, dancing, computer literacy skills, and vocational skills and trainings. So the data from implementing this Operation 000 shows that as the number of adolescents enrolled in care in the center increased, the viral load suppression continued to increase. At the beginning, it was 79%, which increased to, as of September this year, to 93% viral load suppression. So the lessons learned that adolescents and young persons have other interests beyond ART. So if we address their challenges, we tend to get them more committed. Specialized care also improved overall treatment outcome. Then adolescents and young people's commitment to self-care. Commitment to self-care is very important and makes adherence easier. Caregiver involvement is also very important and a key aspect that should be implemented across. Then non-judgmental approach to counseling is very vital to adolescent commitment to self-care. Thank you. This presentation was made possible with support from the US President Emergency Plan for AIDS Relief and USAID. Thank you all.
Hi, I'm Rebecca Sher, talking to you from Cape Town, South Africa. I'd like to share my experience of developing peer-led support groups that bring together adolescents with many different chronic illnesses, including HIV. This program is based at Groote Schuur Hospital, which is a large tertiary center in Cape Town. At Groote Schuur, adolescents with a diverse range of conditions are seen in various specialist clinics. When some of us working in adolescent care across different specialties got to chatting with each other, we found that despite their different conditions, many of our adolescent patients were struggling with very similar issues of illness-related stigma and isolation. After consulting with our patients on their needs and preferences, we selected and trained peer mentors living with a variety of different chronic conditions and set up a weekly support group that is open to any adolescent who attends Groote Schuur Hospital. We were fortunate that One-to-One Children's Fund showed an interest in the program when it was still in the pilot phase, and they've been our partners in its development and rollout since 2018. Next slide. Our target population is any adolescent who attends Groote Schuur, and this includes those who are currently admitted to hospital but are well enough to attend group. Our groups are truly mixed, with adolescents living with HIV, mental illness, kidney disease, as well as endocrine, respiratory, and other conditions all coming together in the same room. We welcome adolescents aged approximately 13 to 21 years, while our peer mentors tend to be 20 years or older. The hospital's drainage area is very wide, so group members tend to come from all over the Cape Town metro, which makes our groups socio-demographically diverse. Next slide. Looking at the building blocks of the program from the point of view of HIV care, we're an intensive doctor-led service, as you might expect in a tertiary hospital. We see so-called high-risk adolescents referred from primary or secondary care, as well as those who have aged out of their pediatric service. Stable patients are usually reviewed 4 monthly, while unstable patients are seen monthly or as required. As well as HIV care, we attend to general health issues and address sexual and reproductive health care needs. Medication is dispensed at the hospital pharmacy, usually with 2 monthly refills. Our support groups run weekly on a same time, same place principle, with the expectation that adolescents will drop in when they are on site for clinical care or pharmacy visits. We run the groups in a neutral and non-medical space within the hospital. 2 peer mentors are rostered to lead each group and are provided with ongoing in-service training and feedback by a psychologist. What I really want to bring out here is that the groups are not focused on illness and certainly not on adherence. Our adolescents have made it very clear to us that they are tired of talking about these issues. Instead, the focus is on life, relationships, friendships, sex, the future, and all the other things that adolescents are more interested in. Disclosure of your illness isn't requested, but our teens have told us that they find it reassuring that everyone is living with something. Next slide. Since we began the program in 2017, group attendance has been steady and sustained, with a bit of a dip last year due to COVID. You can see the wide variety of medical conditions that group members are living with HIV comprising the biggest group. Next slide. The feedback from group members has been very positive, with themes emerging of enjoyment, improved coping, and decreased isolation. This is illustrated in some of these quotes from participants. "I never thought that I would have so much fun. You come out of that group feeling more alive than when you went in. I don't feel as alone as I used to. It has made a huge difference even in my life coping with my disability." Next slide. So in conclusion, our experience has been that it is acceptable and sustainable for adolescents with a wide range of chronic conditions, including HIV, to form mixed groups to support each other. These groups may help to decrease isolation and stigma related to chronic illness. We'd like to measure the effect of group more precisely, so we're in the process of conducting a study to measure the impact of group on mental health outcomes. We are also excited to help other facilities to start similar groups and have developed a manual with our partners at One-to-One. If you would like a copy of this, please get in touch with the One-to-One team. Thank you for the opportunity to present.
My name is David Ogiti. I'm talking to you today from Migori County in western part of Kenya. In the next 5 minutes, I will present some program data on family-centered care model for children under 10 years taking care and treatment services. Viral suppression among pediatrics continue to lag behind at 68.9% compared to that of adults at 91.6%. And that is according to the Kenfia report that was released in 2018. And that is why CHEP Kenya with the University of Maryland, Baltimore implemented family-centered care model to improve, implemented a family-centered care model that incorporates families and significant others as contributors and collaborators to improve health outcome. In the diagram on the right, it shows different packages in the PAMA model that are given to these children according to the viral load status. Psychosocial support, family caregiver literacy sessions, clinical consultations, and leveraging on the OVC support are some of the key services embedded within the PAMA model as the building blocks. And this is done either on a monthly basis, every 2 to 3 months, in the HIV clinic, in the hospital, at home, or at the community level. And this is done through the clinician, adherence counselors, peer educators, and OVC partner staff. So in the psychosocial support, this is where we have joint family adherence counseling, engagement of the caregivers, case management for the unsuppressed clients, and children play therapy. For the family caregiver literacy sessions, this is where we have a module that entails health literacy, stigma and discrimination reduction strategies, disclosure support, nutrition and ART medication management, and adherence counseling. In the consultation, in the clinic, this is where we have the clinicians giving a comprehensive standard package of care, medication and ART optimization, appointment synchronization for the children and their caregivers, multi-month dispensing for the stable clients, and joint case reviews. Then leveraging the OVC support, this is where we engage the key stakeholders, screening and linkage for enrollment and support, consideration of socioeconomic needs like offering grants so that they can, the caregivers can do some of the income generating activities. And also support for daily drug witness ingestion for those clients that may be failing their ART regimen. So looking at the enrollment uptake and viral suppression, so the trend on the left shows the enrollment from the time we initiated this model, and indeed there's been greater improvement as currently the program is doing at 93% for those children taking HIV care and treatment services in 237 facilities. And for viral suppression, the trend has really improved as currently the program is doing at 90%. And as per the cross-sectional analysis study that we did, children in the post-implementation period were twofold more likely to suppress than those in the pre-implementation period. So as a program, we've learned that family unit engagement comprehensive psychosocial support, tailored differentiated care models, structured engagement of visit programs designed to better support children and their families, may improve clinical outcomes among children living with HIV in resource-limited settings. Thank you.
Hello, my name is Cosima Lenz. I work for the Elizabeth Glaser Pediatric AIDS Foundation, and I'm going to be speaking about making extended refills for ART for children and adolescents a reality. As illustrated by the graph, the proportion of children and adolescents, those under the age of 15 on multi-month dispensation has steadily increased over time. And this is a proportion of those on ART across 10 EGPAF supported countries in sub-Saharan Africa. It is important to note that this curve doesn't reflect the same trend for children under 5. So there's numerous strategies that have been employed to scale MMD or extended refills for children and adolescents. This includes support for revision of DSD guidelines to include comprehensive guidance on DSD models for children, including MMD, integration of DSD model provision into trainings for providers, orienting supervisors and providers on eligibility criteria of children on ART who can be included in MMD, and providing follow-up support and monitoring. Providing financial support for MMD. This includes transportation fees to community workers to support pickup of ARVs at the facility and bring them to the community level, forecasting and quantification at facilities to ensure that there's enough stock, and facilitating redistribution of pediatric ARVs from facilities with sufficient stock to facilities with lower stock. So in order to ensure MMD provision for children and adolescents in Lesotho, there are numerous sort of elements that were employed. And the first was certain common barriers to MMD were addressed. And this includes getting buy-in from the Ministry of Health supply chain to ensure that there's adequate drug supplies. So collaborating with the supply chain and redistributing within districts for prepackaging of MMD. Having supportive MMD policies in place. This includes provision for children who are 2 years or older, and addressing healthcare worker confidence in prescribing MMD. In terms of MMD provision, there's routine assessment for MMD eligibility as per guidelines. There's systems to actively notify patients and facilities if a patient is no longer eligible on MMD. And there's ARV optimization for treatment experienced patient and minimization of barriers to full implementation of MMD. EGPAF Lesotho also collaborated with Ministry of Health technical working groups to ensure that MMD occurred beyond just ART. So this includes TB, PrEP, and contraception. There's also rollout of telephonic check-ins for clients who are offered 6-month MMD. As we can see, the overall high coverage of pediatric MMD at 60% occurred in Lesotho, and this was over the course of October 2020 to September 2021. So how did EGPAF Lesotho get to 60% coverage? So they implemented or integrated MMD in specific models that meet the needs of targeted populations. The first being ART refills for children and younger adolescents using a family-centered approach to enroll clients on same-day MMD refill dates as their caregivers. So this ensures that family units are given appointments in the same day and that family members can pick up ARVs on behalf of somebody within their family. And this would only be in the case that there's no medical consultation necessary. The second is sort of in addressing adherence concerns, particularly for children in the care of elderly caregivers. So this includes provision of pill boxes, adherence care cards, but also attaching a village health worker to these children for additional monitoring. And the village health workers receive training to make sure that they are competent in supporting these children with weight monitoring or adjusting pediatric doses based on the scenario. In terms of adolescents, there are specific strategies that were employed for this population. So EGPAF Lesotho, in collaboration with partners in 9 tertiary institutions, provided MMD to students. So by December 2020, for example, of the 491 students active on ART, 91% were on MMD. MMD was also integrated into existing service delivery points for adolescents, which includes adolescent quarters. Adolescent quarters are specialized spaces provided comprehensive services to adolescents and youth in a youth-friendly and responsive way. And this includes MMD through the use of peers and multidisciplinary service approach with multi-service delivery teams. And they're available in specialized spaces, and also services are available in the mornings and weekends. And as you can see on the chart, there was a 71% coverage of MMD of adolescents attending quarters. So in conclusion, various approaches have been used that have been successful in this scale up. And this includes a systems level approach to support MMD provision, for example, improving policy, ensuring supplies, and building capacity, and implementing tailored strategies to meet the needs of adolescents and youth. For example, the facility-based or adolescent quarter approach, as well as capacity building of facility and community-based cadres to support ongoing provision and adherence support, particularly for vulnerable children. Thank you so much for your time.
Good afternoon, everybody. My name is Franklin Emerene. I work in RISE Project Nigeria.
Good day, everybody. Good day, everybody. My name is Untitled Charles. I am an adolescent champion working for CHI as an adolescent peer supporter in one of the public health centers supported by CHI in Akwa Ibom, Nigeria. I'm going to be sharing my experiences with you all about my very important role as an adolescent champion supporting the distribution of HIV self-testing kits amongst my peers. As an adolescent champion, I get to also mentor my peers and talk to them about adherence, disclosure, and positive living. Next slide. In April 2021, I and 3 other adolescent champions were selected by CHI from four youth-friendly facilities, both in Akwa Ibom and in Anambra, and we were trained on HTS, on HIV self-testing, identifying eligible clients, and how to give guidelines to adolescents on how to use the HIV self-testing kit. HIV distribution and how to do the HIV self-testing kits. We also talked about the data managing is very, very important in the work I do. So I do collate data and document them at a monthly and daily basis. I fill the daily registers and the response and referral card, and also the monthly summary form. These are done for daily and monthly basis. In distribution, that is the main aim of the work I do. That is the primary goal. I came up with some innovative ways to distribute that involves social media approach. Apart from my primary role, which is to be distributing these self-test kits at my facility, my public health facility, I base at the youth-friendly office. So adolescents will come in, to seek support for either STI screening, or those that are reactive that are coming to get refills or drugs. So they get it for their partners because they are literally sexually active. So I also use social media, and I go to the community to distribute the HIV self-testing kits. Next slide. Easy usage, privacy of use, all these have been what has recorded the success so far. The achievements from April to August is what you're seeing here. I am happy to say that I have been able to contribute to this data here. I have distributed a total number of 80 test kits, and all tests that I have distributed, tests were conducted on them, and all their results were reported. I am also happy to say that I had a total of 2 reactive clients, and also were referred and linked for complementary HTS, and 2 of them were identified to be HIV positive, and all of them were linked with care. I am greatly happy about my work and my achievements so far as an adolescent champion, and as a community to distribute these HIV self-testing kits to my peers. Next slide. Yeah, I know I said it's easy to use, and the pamphlet makes the usage of the HIV test kits to be easier. But since I've been in the system, I've known what works and what could be improved upon. I will also use this opportunity to say that when going to the field to meet these adolescents, most of them that have been doing this test with other centers that are using the conventional rapid test kit will tell you, oh, when we do get there, we do get test kits. We do get condoms and other commodities. or you're not wearing any condoms. So I want to appeal that if condoms and other adolescents needing materials would be provided, this would go a long way in increasing the uptake of HIV self-testing kits. Also, one other thing about that is not really working well is awareness. You all will agree with me that HIV self-testing kits is a new HTS strategy, and it's not really well known in this part of the world. So I really want to say that we all should increase the usage of IEC materials at walk-ins, support groups, at their facilities, entry points. This will also enable adolescents to get to know that, oh, okay, we could rely on the results of this test kit. And to also know that, okay, HIV self-test kit is just like the other one, but it's more better and private and everything. So, okay, that in conclusion, I would also like to tell you all that we must involve adolescent champions who play an important role in increasing case detection and bridging the gap between adolescents living with HIV, health providers, and the community. Thank you so much, and I'll take questions later.
Great. Thank you so much, Dorian, for doing that presentation live. And I want to invite you to stay on camera, and as well to invite Rebecca, Cosima, Franklin, and David as well to all turn their cameras back on. We're done the formal presentation part of this session, everyone. So we're really excited that you're here in our Africa Cafe, and we want to hear from you. So the first way that we want to hear from you is in this set of polls. And what's exciting is that these are polls that only you can answer as attendees. So none of us who are panelists can answer these questions. And so this is really going to be your view. So we have a number of questions here, just 3, about your setting in your country where you work to find out a little bit more. So our first question is, in my country, children and adolescents can access DSD for HIV treatment. The options are yes, no, and I'm not sure. Secondly, we want to know where you work. Can children who are established on antiretroviral treatment receive 3 months of ART refills or longer? And third, where you work, can adolescents who are established on antiretroviral treatment receive ART refills of 3 months or longer? And then finally, if you scroll down on your poll, you'll see there's 2 more. The fourth thing that I'm interested in is wanting to know, are adolescent peers a recognized and valued cadre within HIV service delivery where you work? And then finally, where you work, are adolescents able to access HIV self-test kits? Now, I can see Franklin, I can see Cosima, I can see Dorian, David, and Rebecca. Excellent. So Dorian, I'm going to start with you, because while you were presenting, there was a number of questions that popped up in the Q&A, and you can't present and type, but everyone else had pre-recorded. So I think our audience got used to that, and that's not a problem. So maybe if you could just give our audience a little bit more detail about the youth-friendly center where you work. People would like to know who funds this, how does it work in terms of reducing stigma, and how do you ensure that adolescents who you provide HIV self-test kits to know where they can get the access to care, treatment, and support that they require? Should they require more prevention services or more treatment services? So while you're answering the polls, everyone, I'm just going to ask Dorian to tell us a little bit more about where he works in Nigeria. Go ahead and unmute yourself.
Okay, about the Youth Friendly Center, you asked who funds it. It's funded by USAID and supported by CHI, Clinton Health Access Initiative, and also the support from the by the government of Nigeria. Yeah, so it's a Youth Friendly Center, as it seems, and adolescents and peers about my age are free to come in, ask questions about, sexual and reproductive health. They also get to, some that are in care, come to get refills, viral load, so that's just, it's a way where adolescents see it as a safe space for adolescents.
Great,
Yeah,
and so someone was asking a follow-up saying that they think that one of the biggest challenges with HIV self-test kits is whether or not people return back to the facilities if they require further support. What has been your experience with that in terms of building a relationship with people that you distribute the self-test kits to, and ensuring that they do come back to either your center or somewhere else if they require services?
Okay, meeting adolescents, first we have to identify their eligibility for this test kit. So once they're eligible and I give out the test kit, in the referral and response card, I do have to get their phone numbers, their address, and other vital informations that are usually there. And I do call like a day or two to confirm if they have done the test. Some are like, oh, I've not done the test. I'm going to do probably they're scared, or they're scared of being at risk. So they're scared of doing the test and have to turn positive. So I do call to confirm, and when I call, they'll say I'll tell them to, if possible, to send me a screenshot of the entire result that displayed, so I will now be able to interpret the result for them, even when they are confused.
Thanks so much. I just want to check in with my colleagues here and say, you're welcome. I want to give the attendees actually just 2 more minutes to answer the polls. So you should have a poll box that has appeared on your screen. And if you can answer those questions, that'll help us have an idea of where you are and where you work. Franklin, you presented first and you've been busily typing for the last 30 minutes or so. I wanted to know if you could just give an answer now over the video chat to one of the questions. We had someone who was interested in how home-based delivery of services went and what the experiences were there. And I wanted to let you speak to that a little bit now.
All right, thank you. And thank the participant for asking such a question. From our experience, the home-based care is one of the major successes we had in pediatric and adolescent care in our project. Though it was happening at a small scale, but when COVID came on board and there was movement restriction, which stopped most people from coming out. So it became a problem, and many of them were at risk of getting lost. So we trained some healthcare workers who are the case managers, and then we were able to obtain government permit to allow movement during that lockdown. So with that experience of receiving that pass, we were able to visit individuals because during the visits, we were able to update their home addresses, their phone numbers, and then there's a GIS mapping, which we will be able to use a geographical information system to locate their homes. So book appointment, make a phone call to them and book appointment with them, and then supply their drugs in their houses. So with that experience, we discovered that with it, we were able to meet up most of the patients without them getting them lost to treatment. So we scaled it up at a much bigger rate. So now it's very efficient in helping and making sure that these individuals receive their care. So in terms of logistics, so individuals have their specific case manager. If in the pediatrics, what we did also was we discovered that by December 2019, we discovered that we are having a higher percentage or proportion of children and adolescents getting lost to follow up. But the overall viral coverage was high, 80-something to 90%. But when we disaggregate, we discover because our children were making like 5 to 6% of the total population. So we disaggregate and find out that they were getting lost in the pool, what I may call they get missing in the crowd. So specifically, we pulled out the children and adolescents specifically and assigned them to specific individuals who take care of them. So we now use some standardized models to train these individuals to especially handle specifically children and adolescents only, leaving out the adults. So these individuals now monitor these children and adolescents. If they get lost to follow up, because of that close communication and relationship, there was more like more of a friendly relationship, going beyond the healthcare worker and patient relation to more like friendship relationship, a friend and family friend relationship that existed between our clients and the case managers. So they developed some form of attachment and relationship, so that some of them even calls those who have phone calls, the adolescents have phone calls, can, at the point of their need, call their case managers who are healthcare workers and explain problems with them outside working period, odd hours. So that facilitated movement. So the program made provision for transportation support to visit these children in their houses. So the case managers are also given the transport support, and then they are also with the peer support, of which Idren is one of those trained by CHI in their own project, but we also have our own project as a specific. We have, wherever we have a adolescent center, that is OTC club, there are at least two adolescents and young persons who have been trained to be peer supporters. So they do home visits. They even assist them when they come to facilities. So during that home visit, as it needs, if a client misses appointment or misscheduled or was not seen in the club for one for the day, by the next day, the phone call we put across to find out what has happened. So if he couldn't come within 2 days, the responsible case manager and the treatment supporter makes that move to visit them in the house. So it was very efficient and it helped in maintaining drug. And then one thing we also had to do was, when we discovered it was giving us success, we integrated other services into it, things like viral load sample collection for those who are due. Instead of going to their houses and then asking them to come, we trained some lab scientists and lab technicians essentially, who go there and do the phlebotomy, collect the blood samples using Jablo boxes. What we call Jablo boxes is this same thing that's used for rural immunization project. There's one cool pack that in this part of the environment, when they're going for rural immunization, they use it to store the vials so it doesn't get spoiled. They go into the communities and do immunization. So if they could do it for immunization, we can also do it for viral load sample collection. So procure some of them, they are packed with ice to ensure that the integrity of the samples are collected. So they carry the boxes and go into the community, visit the particular individual, collect the sample, put it back into the ice pack, and bring it back to the reference lab. Thank you.
Thank you for that. So I think what is really interesting about this session is that the brief from PATA was that we should talk about children, we should talk about adolescents, we should talk about testing, we should talk about treatment, we should talk about HIV, and we should talk about other health needs of children and adolescents and young people. And somehow between all of your presentations, I think we've managed to just touch the surface of all of those issues. So those are some of the things that I want to try and cover in the next 40 minutes or so with all of you. So what we're going to do is we're going to talk through these poll questions a little bit, and then we're going to try and transition to the Jamboard, where I can see that there's about 24 people putting some sticky notes on our virtual whiteboard there. I wanted to first turn to Cosima to talk a little bit more about children and adolescents, or children specifically. One of the things that we've observed is that there was a huge barrier in order for clinicians to be comfortable with extending the duration of ART refills for children before COVID. And now we've seen a huge shift in a sizable proportion, more than half of children in PEPFAR supported programs having at least 3 months of ART refills. And when you look in our poll questions here, you'll see that 72% of children could receive 3 months of ART or longer, compared to 87% of adolescents. So there still seems to be some hesitancy around some of the younger ages. And I just wanted to give you a chance to reflect on that and what you think is going to happen going forward, and if this shift towards extended refills for children is something that's going to persist for years to come.
Yeah, absolutely. Great question. Thank you, Anna. I do think that over the last period of time, we have seen this increase. As you noted, that the increase hasn't necessarily been as large for those who are younger compared to those who are between the ages of 10 to 19, for example, those in the adolescent sphere. And that, I think, is for a number of reasons. I mentioned one of them in the presentation. Some younger children are under the care of elderly caregivers, and it's a little bit more challenging to be able to monitor MMD. Sometimes there's more complex cases that becomes a little bit more challenging, especially in rural areas, like somebody's question alluded to. So there's a little bit more complexity, I think, especially for the younger ages, though there has been an increase over time, like we've seen. And I think based sort of on that trend, I think it's starting to show that this is feasible, this is possible, and it's probably gonna lead to more increase over time.
Excellent. And Dorian, here you'll see that of the people that answered our poll, 85% said that peers, in this case, adolescent peers, were a valued member of the team that's providing services. And just about 50% said that adolescents could access HIV self-test kits. I mean, you have a lot of experience now in terms of being a valued member of the service delivery team. And I wanted to know if you could just give us a little bit of insight as to why you think it's so important that young people are involved as providers within the healthcare system and really valued as providers.
Oh, okay, thank you so much for the question. Why I think young people needs to be at the forefront of providing HIV services is, okay, when it comes to our targeted population, that's young people, I do think that young people should still be the ones on the forefront at service delivery and distribution of HIV self-test kits, because I see a young person would literally want to communicate with another young person when they see me, we are peers, and I come to them, I talk in the language that they do understand, because I don't think an older person will be able to talk to them and get sensitive information from them the way I would be able to. So as a young person, meeting my peers, I will just, we'll talk and ask about a few of his, about his risky factors, if he has been exposed. He'll be free to disclose this with me than an older person. So yes, young people, I think young people are right to be at the forefront of service delivery. Because like I said, a lot of young, okay, there's someone in distribution of the self-test kits. I meet a lot of people on the facilities, and when they come, maybe they're not really comfortable with the a little bit elderly people, so they would always want to come to me. Hi, Dorian, how about please, can I have the test kit? I have a session plan I need to give. So I see that there have been they choose to come to me rather than the other nurses, and because I think it's because of the age difference, because they feel that they're comfortable, talking to me. So that's just it.
Great. No, that's super insightful. So you'll see now that we're projecting the Jamboard that many of you are trying out, and I'm really glad that you're all writing in different languages and saying hello to us. We can move on to the second slide of the Jamboard, or actually the third slide now, and get into the barriers and the facilitators in a moment. I first wanted to ask Rebecca a bit of a follow-up around the model that you are using at Sher, and ask about, as Dorian talked about, the value of adolescents in terms of being providers. And if you, in this model yet, have much experience, this was one of the questions, in terms of supporting adolescents to transition into adult care, or where the young people living with HIV in your model graduate to after their time in this integrated model at the tertiary facility.
Thanks for the question. Yeah, I mean, transition is still quite a sticky issue, I think, for a lot of us in adolescent care. And for us working at a tertiary hospital, our adolescent clinic is seen as quite a high risk service. So struggling adolescents from all over the place come in to see us. And there is an adult infectious disease clinic at the hospital, but it's much more of a straightforward medical clinic, and usually for people with complex medical conditions, not necessarily psychosocial issues. So we don't actually have an equivalent service to transition our adolescents into. So some of our older adolescents, I think one thing is that we're just not too strict about the upper limit of adolescence. So if someone is going through difficult times and they're 22 or 23, we will keep them until we can stabilize them. The stable patients generally need to transition out to primary care, so that can be a bit difficult to have to actually change facility. And patients who are unstable or need ongoing support will then transition to the adult clinic at the same hospital on a different day of the week.
Right. Thank you. Yeah. And I think that's a good point. You did a great job in your presentation of emphasizing kind of how this was a tertiary hospital model and the different layers of the healthcare system here that the young people would be moving between. David, I want to make sure you're still online. I can see you there. And you can see this Jamboard here, and there's a number of barriers that people have mentioned to scaling up DSD for HIV treatment. So you can see people are saying there's low confidence among the health providers. It requires changes at the facility and people are hesitant to make change, that maybe the providers feel that they lack skills. There might be a facility that is just for children and adolescents, and that would obviously make a family model a little difficult. I wondered if you could speak to your experience with any of these barriers and maybe offer advice for how to overcome some of these barriers for people who are interested in adopting a more family-centered approach to the provision of HIV treatment.
Okay, thank you. So I know there are a lot of barriers that people are still experiencing. So one of the some of the things that we did when we were starting this model was just to ensure that the healthcare workers are sensitized and trained so that these barriers can be overcome. And if you look at these barriers, we have some of them are, I know some of them are system related, okay? Just the way some of the participants have mentioned that we have the resistance from the healthcare workers, and that one, I think giving a good sensitization and training, then we may be able to overcome. So we've seen a lot of barriers, but I think with time, this one will improve. So like in the system issue, things to do with commodities, I know it is still affecting the issue of implementing the DSD. Most of for the commodities, you're having low stocks or stock out of some of the commodities. So these are some of the things that may hamper the scale up of the DSD model. Also, even if you leave the system aspect of it, we've also seen also from the client themselves. So from the client themselves, there's also the issue of the stigma that is still there. But I know this one has really reduced as per the model that we've implemented. So this has reduced. So stigma issues is still there, but it has reduced. Another thing is on the issue of the, we still have clients having hesitancy to get detached from the clinic. So there's that fear that if they get detached from the clinic, then they feel like they will get like lost from that clinic. So that is still affecting the uptake of the models. Another thing is if there was no proper information given to the clients at the beginning when this model or when you're initiating DSD, then that one is going to affect the uptake of the services. But I believe as the time goes by, because even if you look at, even as for the data that we presented, if you look at the time that we started, the enrollment was not so that much. But I think there's been greater improvement, and more so during this time of COVID. So with good information to the clients, and also just working on the system to ensure that you have good commodities and capacity building the healthcare workers, then I think we are gonna improve in terms of DSD uptake. Oh.
Thanks, David. Turning now to Franklin and the facilitators, some of these are things that we would expect to see a little bit. We see a lot here about engaging adolescents and engaging young people and making sure you have adolescent-friendly health providers. What would be your one piece of advice for someone who was somewhat hesitant to start a DSD for HIV treatment model for this population? What would be the one thing that you would tell them?
Okay, thank you for the question. We experienced this thing at the beginning when we were about to scale up DSD models. So some healthcare professionals will be hesitant to start. So what we did was to present evidence, because we ran an analysis comparing viral suppression among those on DSD models, MMDs, and those who are in the regular healthcare facilities. And there seemed to be even better suppression among those who were those who were in DSD models than those who were attending the regular facilities. I think most people, being that they are healthcare professionals and also being in the field, people don't argue against evidence. So what I would advise, though, if you want to implement it and you're getting resistance, try to generate evidence and use the evidence to go ahead and engage with the healthcare professionals. And I will also, on a general note, make it clear to the healthcare professionals that the DSD models are doing well, and children who are in DSD models are doing very, very well, so, and sometimes even better than those who are in the regular package. Thank you.
Great. So Franklin's made the point that we can use evidence to convince people to change their mind. I think that unfortunately, not all of us always follow the evidence. We sometimes need a story, or we sometimes need a nudge, or we sometimes need a personal anecdote to help convince us to change, right? Change is difficult. So I was just going to open it to the rest of the panelists. I agree, we definitely need evidence, and we've got some good evidence to show providers, but what else could we do in terms of encouraging someone to take that first step?
Just to start, based on your input in terms of the narrative, I think that's a really critical point. For example, in some of our trainings that we target health providers across this cascade at facilities for building up capacity for MMD or other DSD models, we try to intentionally include young people, young clients in the trainings themselves to sort of provide that youth lens, that youth perspective, showing why this matters for the clients they're supposed to serve. So trying to sort of shift the narrative so that they understand the reasons behind this change in implementation.
Thanks, Cosima. So I'm going to turn to Rebecca now, who gave us this great presentation highlighting how at the tertiary hospital they're providing a group model for young people with chronic health needs. So not just HIV, but other chronic health needs. And I wanted you to speak a little bit, Rebecca, to your insight as to whether or not this is something that's works because it's an adolescent and young person population, or if you think this is something that should also be considered and implemented for adult population. We often try and take adult lessons and move them down to younger age groups. And I'm wondering if this is an example, in your opinion, of something that we've learned from young people that could be used for older populations.
Thanks for the question. I mean, it's a really interesting idea. I have to say, in my own experience, adolescents are just so much more open-minded and willing to take risks than adults. And I'm saying this, you know, working in a clinic where on our pediatric days we support younger children and their families, and to get some of our parents to attend support groups has been quite a mission. They're quite resistant. Whereas our adolescents are really kind of quite keen to give it a try. I think basically that's it's a really interesting idea, and you know, it also speaks to other illnesses not being left behind. You know, HIV is often kind of at the forefront of innovation on all of these issues, and yet people living with other chronic conditions sort of keep going with the old ways of doing things much longer. And it has been kind of amazing with these adolescents to reach out to the other kids in the hospital and offer them some of the same things that the patients I see on the HIV side, you know, are able to access. Excellent.
Dorian, maybe over to you now. We're on this Jamboard slide about what is needed to provide services beyond just HIV. And I really would be interested in your opinion. What are the other health needs that young people have that they want to have support for in terms of counseling support or commodity support, and what is really needed to make that happen? Rebecca's talked about how HIV is often this lens of innovation into many things, but we do know that if we only offer, for example, HIV services here and then sexual and reproductive health services here, that it doesn't really make sense in terms of an efficiency for the health system or for the person, because they would have to come back twice and they would have to see two different providers. So what do you think it's really going to take for us to provide services that are beyond HIV? And what would be the benefits to young people if we were able to do this?
Okay, apart from providing services for HIV, we could also implement in other factors regarding health, like STIs, and also most of young people. I think if programs like income generating activities are being brought up, that could help to keep most of these adolescents to be independent, and they will be able to afford and eat well, to have a healthy, to live health and have positive living. So if income generating activities are being sponsored and brought up, so adolescents could now earn a living, because most of them are going through school. Most of them do not have money to have a work. They're not working, so they really need income generating activities to help them. Apart from HIV services, this could also come to aid the adolescents to have something doing. So that's just what I see.
No, that's great. And I think you've brought it even broader and highlighted how it's not just health needs. There's other ways to attract young people into services that are beyond just health in terms of income generation, career development, etc. So we've got one final poll set of questions up for those of you who are engaged still. So we're wanting to know about how COVID has impacted the HIV response in your setting, if there's been any silver linings for the HIV response from COVID, and then what is required for change in terms of revising policies or in terms of further promoting scaled implementation. I want to just go to the last Jamboard slide here. And again, there's a lot of interest on how to implement peer support in their facility and what is needed to provide adolescent-friendly health services. So maybe we can just do a quick, not so quick, but maybe just a sentence each on what would all of you define as adolescent-friendly health services, and what should that person be looking for in order to support implementation? Who wants to go first?
Okay, let me go first.
Thanks, Franklin.
All right. From my own end, I think adolescent-friendly service is a service that is responsive to the needs of the adolescents, and it should be acceptable to the adolescents, meet their basic needs, and it should be in such a way that where the adolescent himself is made a co-creator of the healthcare system, not just a recipient or a passive individual that passes through, receives instruction, but should contribute to the establishments of the system and make provisions, and their voices should be heard. So basically, thanks.
That's excellent. Anyone want to add on to what Franklin said? Cosima, I see you're unmuted, and then Rebecca.
Sure, just building off of that, because I completely agree with that point. Making sure that there's comprehensive services like we just mentioned in terms of meeting the whole holistic needs of the young people, and making sure that those services are available in accessible spaces, accessible times, including peer support.
Yeah, I completely agree as well with what's been said already. I think for me, if you're looking at the word adolescent friendly, I think the real key is the friendly and to the non-judgmental. And the adolescent, him or herself, has to feel welcome in the space.
David, any additions there?
I agree. I think looking at adolescent-friendly services is the key thing, and going beyond the clinic, just going beyond the clinic. An example, I think we've had an activity in the program whereby during school holidays, without focusing on the treatment aspect of it, during the school days, now you will engage adolescents in terms of the games where they play, and it is really something, it's really a good thing that motivates them. So we need to look at what can we do beyond the clinic services. Oh.
That's a great point. So taking services outside and meeting adolescents where they are. So you can see now, and this is a really interesting set of responses that we've gotten on the polls here. So in the opinion of our audience, 90% think that COVID encouraged frontline providers to think differently about how to best provide services. 72% thought that it encouraged innovations on how to provide services, and 59% thought that it accelerated the scale up of DSD for HIV. On question 2, we heard as to whether or not you thought that there had been some silver linings for the HIV response from COVID. And we almost have an equal split here between, well, strongly agree and agree, which is great. Some are not sure and some disagree. In terms of what's required to support revising policies, people think we need evidence, 54%, but 82% think we need more advocacy. And I would agree with that quite strongly. And so I hope that we can consider all of you who are attendees here today to be advocates and to use some of the examples that were shared from the presentations today and use some of the tools that are available through the PATA Hub to advocate for DSD for children and adolescents in your setting. And then finally, again, in the same way, 77% of you think that greater advocacy and demand creation among communities and people living with HIV are necessary to drive implementation. In the last 4 minutes, I just want to give everyone a chance to give one key takeaway from this session. So I will go in the order that I see you all on the top of my screen. So that's Rebecca, David, Cosima, Adorian, and then Franklin. Go ahead, Rebecca.
Haven't had much time to think about that. I'm going to just say a takeaway from my own program, which is that bringing people together, HIV positive and HIV negative, can actually decrease stigma rather than increase it.
Thanks, Rebecca. David?
So thanks, everyone. My take, I think, will just be scaling up DSD services is a good thing, and it is something that is going to improve the quality of services that we give at the clinic level. And again, it is something that will also lessen the burden to the clients and also at the facility level. So it is something that we need to look at and implement with fidelity. Over.
Thanks, David. I think it was Cosima next.
Thanks. I think just highlighting the feasibility of implementing these different models while also ensuring this engagement with different stakeholders across sectors, also providers and clients themselves.
Dorian?
Okay, in conclusion, I would like to say that we should engage more adolescents in the cascade of HIV prevention and treatment. You know, this would also aid in the targeted population of adolescents. So more adolescents should be trained and, you know, put in place to HIV prevention. Yeah.
Thank you for stressing that. Franklin?
All right, thank you. In conclusion, I would like those who take care of children and adolescents should always look beyond the virus. Let's have an idea that these children and adolescents, they have a future, they want to grow. So many other things matter to them beyond HIV and viral suppression. So as much as we are treating and taking care of them, we should also think after they must have gotten suppressed, what next? How do we keep on engaging them beyond just the message of take your medication and get virally suppressed? Some of them, what keeps them in care is a focus on what they want to be in the future. When they link their health to what, if you can link their health to what they want to be and who they want to be, they tend to remain more in care than just viral suppression and death. Most of them don't understand what we mean by that. Thank you.
So with that, I just have a huge thank you to the PATA team for giving us this opportunity to put together this Africa Cafe session. I want to thank all the presenters and panelists for your work leading up to today, for joining us today live, for keeping your videos on and sharing your insights. And we hope you have a great rest of the summit, and we hope to hear from you more. And for more about differentiated service delivery, you can email us at dsd@iessociety.org or visit differentiatedservicedelivery.org. Thanks very much, guys, and we'll see you next time.
Thank you.